an option, but it's not. I don't think it's gonna work for me. I'm sorry. I was so confident. Oh, yes. Recording has started.
Okay, great. All right. Well, I'm going to jump into it, and what I want to start out with is actually something I just saw this morning on the internet. I'll start sharing my screen. And if at any time there's technical difficulties, just speak up and tell me. Here we go. Can you see my screen now? Should look like a giant purple square.
Yes, we
Okay.
do. Yes.
So this is a report from Mental Health America that just came out, and this is 2023 data, so they're kind of projecting. And this is the state of Oregon, if you can't recognize that square. And if you see it says 50. So the top says adults with serious thoughts of suicide in 2023. Oregon ranks 50th in the nation. So that's not good. 6.8% of our population have serious thoughts of suicide. So just wanted you to be aware of that. And I think, here's the list you can see. And this is a great website to check out. It's got all sorts of cool statistics. Did not receive treatment. Adults with AMI, I'm not sure what that means, but a mental illness maybe. So we're 34th in the nation there. 54.1% of the people with a mental illness did not receive treatment. So more than half, and we're not even the worst in the country. So that's the state of mental health in America and in our state. Just wanted to share that real briefly. And then I'll go back to the beginning of my presentation. Sorry, I wasn't at the beginning. Okay, so a little bit of context for you. And healing from trauma is what I'm talking about today, but I know also you wanted some tips, right? So I'm going to give you some strategies rather than tips on how to work with people who have trauma in their lives from whatever source. So I'm going to start with some key concepts, just so that we have some definitions to work off of. And I want you to know that this training and most of the trainings I'm doing, my goal is to improve the skills and experience of the healthcare workforce across the state. I cover 3 counties, but I'm really concerned about the state of the healthcare workforce right now, the emotional and psychological state. So secondary traumatic stress is when a professional worker's subclinical or clinical signs and symptoms of post-traumatic stress disorder that mirror those experienced by clients with a history of trauma. Vicarious trauma is a little bit different. It's the cumulative effect of working with survivors of trauma and includes cognitive changes resulting from empathic engagement and a change to your worldview. So this is more of a kind of global change in how you see the world and yourself. And then burnout, which often is the result of these two things, is the cumulative psychological strain of working with many different stressors, often manifests as a gradual wearing away over time. And it leads one to believe that they are not meant for this type of work. So when you hear people say, maybe I'm just not cut out for this, that is burnout speaking. And what we really want to emphasize is that there are ways to promote compassion satisfaction rather than vicarious trauma and secondary traumatic stress. So compassion satisfaction is derived from doing work that helps others, has been found to protect against the development of compassion fatigue and secondary traumatic stress. And vicarious resilience is a process characterized by a unique and positive effect that transforms helping professionals in response to client trauma survivors' own resilience. So in some ways, it's a matter of framing the difference between experiencing secondary traumatic stress and vicarious trauma leading to burnout, and instead having compassion satisfaction and vicarious resilience is about mindfulness in some ways, and what do we think about our experiences after the fact? How much time do we spend focusing on positive and negative experiences we've had? And really, how are we framing the interactions, interpersonal interactions that we're having with the people that we serve? So that's really what we're talking about today, is how do we manage relationships with people who really struggle to have positive relationships, which is an impact of trauma. So what is resilience? This is really what we're going for. We want people to be resilient. It's also called post-traumatic growth. And this is when people adapt well in the face of adversity, trauma, or tragedy. It's the capacity of a system to absorb disturbance and reorganize while undergoing change so as to still retain essentially the same function, structure, identity, and feedbacks. And becoming more resilient not only helps you get through difficult circumstances, it empowers you to grow and even improve your life along the way. So something to think about is, what changes did you have to make as an organization or an individual in your work because of COVID? And are there any you can identify that you appreciate at this point, that you've learned something about yourself, that you've applied and found it works better? That's what post-traumatic growth is about, is looking at the changes that were in some ways not your choice, forced upon you, and still looking for ways that those have a benefit, and maximizing the benefit of those changes rather than staying in the space of this shouldn't be happening and this isn't the way it's supposed to be. The longer you spend pushing back against reality, the more your anxiety and depression grows. And it's a traumatic experience to feel like the world isn't the way that it should be, and we start to take it personally, right? It's now it's an affront to my ideals, my beliefs. So that's what we want to avoid. And post-traumatic growth pulls us in a different direction of seeing where are the positives. So healing from trauma is essential. People who have a history of trauma have more challenges in adapting to change. Mindfulness, radical acceptance, effective stress management skills, which we'll talk about today, and then being able to reach out to others, or having the willingness to reach out to others, is a key part of being resilient. And you'll see at the bottom of each slide, or most slides, I'll have a quote, a citing of some kind, so that you can follow up and at least see where I got my information. So trauma, I think you probably have a good definition in your mind already, but there's a lot of different sources of trauma. And today, I'm kind of focusing on veterans a little bit, but they're not the only people with trauma. And I'll have some resources for you at the end, specific to veterans. But there's a lot of sources of trauma in people's lives, and I'm going to go into that a little bit. So trauma can be just a single event. More often, people who are impacted by trauma have had multiple events. Um, Interpersonal violence or violation, especially at the hands of an authority or trust figure. So that really changes people's beliefs. It changes the way that they see themselves in the world, when the people that they trust the most violate that trust. And then there's structural violence, which is ways that social structures harm or otherwise disadvantage individuals, including experiences of systemic oppression. So talking about marginalized populations there, and the impact, over time, over multiple generations. So SAMHSA has defined trauma through event, experience, effect, and basically saying trauma is in the eye of the beholder. So people define themselves whether they've experienced a traumatic event, and two people standing next to each other can have a completely different experience based on the context that they're really bringing to that experience. So there's an event that's experienced by an individual as physically or emotionally harmful or life-threatening that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So it's not like someone is developing a mental health condition necessarily. It's that they have been impacted by an event to such an extent that anything that reminds them of that event can trigger activation. And we'll go into detail about what that looks like. But it's more like a physiological change has occurred. It's learning, actually. Trauma is a form of learning. Unfortunately, it teaches us that a lot of things aren't safe. And if we carry that belief forward, it impacts how we interact with the rest of the world. So yeah, it's an internal psychological process of learning. So some examples of trauma on the left here we have kind of your, typical list of trauma, but I have a specific list of trauma for older adults and people with disabilities. And I'll be sending this slideshow to Becky right after this, so you can have access to it. You don't have to take notes or anything. So for adults and adults with disabilities, there's a lot more sources of trauma. Pain or medical conditions that significantly limit functioning or life expectancy. So having a terminal diagnosis is a form of trauma. And again, it depends on the individual. How are they responding to it? What context are they bringing with them? It may be more traumatizing for some people than others to have a terminal diagnosis, but what I know is all of the people you work with, or at least most, have a terminal diagnosis. Progressive or disabling sensory loss, changes in vision and hearing, a history of recurrent falls can be a source of trauma. The fear of falling can freeze people, keep them from getting up. Extended or long-standing loss and bereavement, dissatisfaction with your social network, so social isolation is a source of trauma. Preoccupation with physical symptoms, always worried about what's going to happen next, what health condition am I going to develop, and that frustration when things aren't going well physically. And then collective and historical generational trauma, we find that in older adults, there's a cumulative effect, right? So people who have lived longer have had more opportunities to experience trauma. And so you could have, this kind of compounding effect. So COVID-19 has not made things any better. Looking back at the SARS epidemic, this was done to kind of predict how the COVID epidemic was going to go. So this was like I think a bird flu epidemic back in the 90s. People who were quarantined were 2 to 3 times more likely to report post-traumatic stress disorder symptoms. And then 3 years after SARS, healthcare workers were significantly more likely to experience dependency on alcohol or substance abuse than the general population. So this is one reason I'm so concerned about our healthcare workforce is a 6-month quarantine and about 8 or 9 months of disruption in the medical system in isolated pockets of Canada and Hong Kong caused this significant impact on healthcare workers. And we've had a much more difficult time with COVID. And obviously it's a global epidemic. So really the impact is widespread. So a recent study examining differences in older adults with PTSD, so this is from 2022, and older adults exposed to traumatic events related to the pandemic without a history of PTSD, found that higher levels of depression and anxiety among those with the pre-existing PTSD. So people who had a history of trauma before the pandemic were impacted much more by the pandemic. So adults with pre-existing PTSD also were more likely to live alone, experience hypervigilance to media coverage of the pandemic, and said they had more physical ailments. So they were already set up to do poorly during a time when there was a lot of changes in information, things became less predictable. People who already had post-traumatic stress disorder really struggled with that scenario more than people that did not have that kind of history. So social isolation seems to have gotten worse. Again, this is from, at the bottom of the screen is the article, American Society on Aging. And this came out in April of 2022. So during the pandemic, social isolation has been even more pronounced for older adults and those who are immunocompromised and those with pre-existing conditions that put them at heightened risk for contracting COVID-19. So the people that were identified day one, stay home, you're at the highest risk, have had the hardest time. And it's actually resulted in what we call internalized ageism. So the people that are impacted in this way by the pandemic, thinking about that they are at that greatest risk and need to take the most precautions, have become less optimistic about their own aging and their own future. So as public health officials implemented recommendations to reduce transmission risk for many older adults, mandates for social distancing led to unintended consequences, severely impacting their psychological well-being. And this is long-term care. For isolated long-term care residents experiencing anxiety about contracting the virus, many became highly vulnerable to nervousness, worry, and depression. These mental health impacts were not only widespread among those living in long-term care settings without cognitive impairment, but even greater among those with dementia. Recent data suggests that upward of 60% of patients exhibited worsening cognitive decline due to social isolation because they couldn't have visitors for years in long-term care. So um, I like that this report is really looking at that setting. There's a lot of data out there right now that's looking at community dwelling adults, and it's mostly looking for responses through electronic devices, through email or tablets or something. And so they're missing a huge portion of the population when they're looking at the impact on older adults. So study findings indicated that participants experienced increased loneliness as a function of the pandemic. Nearly 75% of all participants noted reduced or limited socialization while still using video-based technologies. Older adults were having difficulty coping, were struggling with significant emotional difficulties, and exhibited high discomfort in using the new technologies. So not as adaptable and not without the history of using tablets or some kind of electronic device to communicate, it seemed very unnatural to them. In one study, 82% of lonely older adults reported severe depression, 85% reported moderate to severe anxiety, and nearly 40% indicated disruptions in sleep. So all of that is to say, if your experience is that people seem a little more agitated and difficult to communicate with and have relationships with, it's because of that. It's because the pandemic has had a significant impact on our sense of safety, our sense of connection, and our sense of optimism. So the challenges around trauma and older adults are that even some of the vocabulary we're using today, older adults don't have that vocabulary to talk about trauma in a way that associates it with other psychological issues. So older adults lack an understanding of the effects of traumatic experiences, and they don't accurately label such events as traumatizing or traumatic. There's cognitive, sensory, and functional impairments also that might affect the reporting of trauma-related symptoms. So if you're going to think about doing a trauma assessment, um, really talking to other people is one of the better ways to do that. Maybe younger members of the family that have seen things happen over time. They can tell you changes in personality, changes in behavior that might be concerning, and give you a perspective on current behaviors. A lot of people who experienced war hesitate to share those experiences when they come home. They think about the emotional impact, psychological impact on their loved ones before they start talking about these challenging, difficult experiences. Um, and really, their goal is to protect them from that. What's happening? Something's happening. Is everything going okay on your end?
Yeah.
Okay, sorry, something just popped up on my screen here. Um, so what we know is that older adults with post-traumatic stress disorder perform more poorly across a range of cognitive measures compared to older adults without PTSD. So it's a risk factor for dementia, post-traumatic stress disorder. In a sample of 181,000 veterans age 55 and over, those with PTSD were more than twice as likely to develop dementia over a 6-year follow-up. That's pretty young to be developing dementia anyway. And folks who have any kind of a head injury associated with their post-traumatic stress disorder are even at higher risk of developing a cognitive disorder. So there's a direct relationship there. But I also want to talk about adverse childhood experiences or events. So this study was done back in the 90s, but has been repeated over and over. And what they found was when they break adverse childhood events into these categories: physical, emotional, sexual abuse, physical or emotional neglect, and then household dysfunction, people who report 4 or more um, tend to have much worse health outcomes and much higher risk of developing chronic health conditions. So people who have experienced 4 or more categories of childhood exposure have a 4 to 12-fold increased health risk for alcoholism, drug abuse, depression, and suicide attempts, 2 to 4-fold increase in smoking and poor self-rated health, 1.4 to 1.6-fold increase in physical inactivity and severe obesity, and the number of categories of adverse childhood exposure shows a graded relationship to the presence of adult diseases, including ischemic heart disease, cancer, chronic lung disease, skeletal fractures, and liver disease. So there's a direct impact, and it even starts before someone is conceived. So like I said, there's this generational embodiment of historical trauma. So folks that are part of a marginalized group who have not received the same resources, the same access to healthcare, the same access to housing and nutritious food as other people, same access to education and employment and achievement. It all matters, because one generation after another, these things build. So by the time someone is born, they may already be at a disadvantage here and have some trauma. And then they experience adverse childhood experiences, which results in disrupted neurodevelopment, um, which leads to social, emotional, and cognitive impairment, and then adoption of health risk behavior. Now, like I said, we're looking at people a lot of times who have not had access to adequate healthcare, nutrition, education. So when we say they're adopting risky behaviors, um, that's not, I don't think that's really a fair way to depict what they're doing. They're finding ways to cope with what they're experiencing, and the they have access to substances of abuse, much greater access to that than they do healthcare or mental health supports. So turning to alcohol, turning to drugs, um, is logical in a lot of circumstances, because what they're dealing with is not sustainable in their own minds. They can't handle the level of psychological distress, and they don't have access to the care that they need. So that often leads to disease, disability, and social problems, and early death. Now you'll notice that it's a triangle, right? It's not a square. So we're not saying that everyone who fits this criteria of having historical trauma is experiencing early death. As we go up each level, it's a percentage of each group that moves on to the next level. So looking at our interactions with the people that we serve, on a daily basis, people are impacted by trauma. So anyone who's experienced trauma can show these changes in behavior, relationships, and attention. So they can look impulsive, avoidant, aggressive, or fearful. People who have a history of trauma have difficulty establishing trust, making their needs known, and accepting or integrating feedback. Attention, memory, and learning are impacted because brain systems related to sustaining focus, maintaining a working memory, and forming long-term memories may be disrupted. Now, why is this happening? It's because of our neurobiology. Remember, I said that trauma, having a traumatic experience and having kind of integrating that into our lives, our psyche, is not a mental illness. We're learning from our experiences, and that learning can really change the way that we experience life, experience new things. So looking at the changes in the brain, what we have is a higher level of hypervigilance, and more likely that we are going to get activated or triggered or flip our lid. Okay, so this is one way to describe what's happening for people when they are activated or triggered. I think triggered is kind of the more typical word for it, but it also has some negative connotations. So I tend to use activated. Um, so when people are triggered or activated, they flip their lid, which means that they really are losing contact with their prefrontal cortex. And you can make a model of the brain with your hand, just like in this picture, tucking your thumb into the palm and wrapping your fingers over the top. And so when someone's triggered, the prefrontal cortex basically disengages and turns over control to the amygdala, which is the more primitive part of the brain, is the alarm center. So at this point, we're acting on instinct. We're at the fight, flight, or freeze stage. So we're not making decisions that are based on our long-term goals. We're not making decisions based on our relationships, how we want our relationships to go. We're making decisions based on fear and a sense of threat. So we will freeze up. I mean, you probably see this more often than anything else. People just shutting down, freezing up, not communicating. People who are traumatized don't always become aggressive or seem agitated. They typically will just shut down. That's a protective action. So it causes challenges with memory, communication, sensory regulation, executive functioning, and emotional regulation because the prefrontal cortex is the part of our brain that does all of those things. It's what makes us human. It's what allows us to plan our actions. We're able to imagine what would happen if I did X, Y, or Z. And we can think about different consequences and make choices. That's all a very complicated and sophisticated process that requires a lot of brain power. So when that part of the brain is not engaged, we don't make the best choices, and we can really trash our relationships. So how do we help people bring the lid back down? We help them engage in what's called mindfulness, which is really an awareness of how we are thinking. So orienting, helping people to orient. If someone is really triggered or activated, and they are responding in this fight or flight zone, they're not even aware of where they are, what day of the week it is, what time of the day it is, and what they're trying to accomplish. So if you redirect them to those types of questions, kind of open-ended, um, what is it that we're trying to accomplish right now? What is our goal in this conversation or this interaction? Bringing them back to what their intention was. And you can also kind of ask questions like, do you know what time it is? Do you know what day it is? If someone seems really kind of detached from reality. If you know someone pretty well and you have some rapport, you could coach them through some deep breathing. And this is a really good way to kind of break the cycle that has begun, the physiological cycle, by taking deep breaths, because what you're doing is you're decreasing blood pressure. And blood pressure is something that the brain monitors very closely. And a lot of the hormones that are released by the brain are in response to changes in blood pressure in our body. And heart rate, which impacts blood pressure, obviously. So the deep, slow breaths decreased heart rate, decreased blood pressure, and send signals to the brain. You can stop sending out the cortisol and the epinephrine and everything else, all those activating hormones, slow that down, and then release some uh, counter hormones, um, things like serotonin and norepinephrine, to kind of bring the body back to homeostasis. Homeostasis is where we want to be. It's where we feel more calm and relaxed. And so you can really impact your physical senses, and your muscle tension, your blood pressure, by changing your breathing. Grounding is another activity you could coach people through. Let's sit down, let's have a seat and get comfortable. And that can kind of change the atmosphere a little bit. And now let's just feel where our body contacts the ground and kind of stand in that kind of sense of strength and connection, Again, you're going to have some rapport with people before you lead them through some kind of a mindfulness activity. So open-ended questions are good for people who you don't know very well and you're just establishing a relationship with, and really focusing on their goals. Take me back to what you want to see happen here, rather than, focusing on what's not happening, what I haven't done or have done. Okay, what are we going to do now to just make things better? And allow them that space to kind of develop their perspective and share it. So the impact of trauma, to summarize, is relational, because it impacts people's ability to establish trusting relationships. It alters emotional reactions. So folks that are activated have an alteration in consciousness. They're not using the most sophisticated parts of their brain. They're really using the most primitive parts of their brain to try to navigate whatever's happening. So you may not get the responses you're looking for. Psychological and cognitive reactions. So again, if the prefrontal cortex is not engaged, concentration and thinking are not happening. So people have difficulty making decisions in this activated state, and they tend to blame others for things that are going poorly. Behavioral or physical pain is more common for people who have a history of trauma, because they have a lot more muscle tension happening, especially if they're activated on a regular basis. That chronic muscle tension translates into chronic pain. Sleep disturbances for people who are activated or traumatized are very common. People who have trauma tend to have nightmares, and their brain, again, has been altered to the point where it can activate based on environmental stimuli. And it all depends on what has occurred in the past. Stimuli like a sound or a smell, an individual that resembles someone else that was part of the trauma. Um, those things can send signals through the body before the conscious prefrontal cortex is really even aware of it. And so a lot of this happens really outside of someone's volition, out of their control. And so that's why developing a mindfulness practice can be so helpful, and finding other ways to be more aware of internal processes as they're occurring. And substance abuse is more likely for people who have a history of trauma. Um, Trauma impacts our beliefs. It changes our sense of self. What do I have the potential to be in this world? Where do I fit? Can I trust other people or not? And is this world a good place or a bad place? Those basic beliefs are really impacted by traumatic experiences. So trauma-informed care is what we are hoping to provide. A program, organization, or system that's trauma-informed realizes the widespread impact of trauma and understands potential paths for recovery. So it's not just veterans who have a history of trauma, although they have obvious sources of trauma. It's important to look for this in most people because it is so widespread. You have to recognize the signs and symptoms of trauma in clients, families, staff, and others involved with the system. And also recognizing that these interpersonal interactions are not about you, right? You represent the healthcare system. You represent uh, medical services in general. And if someone had a negative interaction with a medical provider, they might be lumping you in with them. It's typically not about you or what's happening in the moment. It's about something that's occurred in the past that someone can't get over. So um, this gives us an opportunity to respond differently. And at the beginning, I talked about vicarious trauma, and compassion fatigue versus compassion satisfaction, right? Or vicarious resilience. And the difference is, how do we respond to these interpersonal interactions? Do we see this as a personal attack, or do we see this as their trauma? And if we relieve ourselves of the responsibility of what's occurring and recognize that this is an impact of something external, it gives us more space to have compassion and empathy for the person who's having this experience. And without that self-blame, we feel more capable, right? We feel like, okay, this is going sideways, but I can save it. I can listen, I can try to understand, I can maybe coach this person to be a little bit more mindful. I can help this relationship develop over time and provide what's called a corrective experience, where someone who has a history of trauma learns or basically unlearns that trauma through their interactions with you as a healthcare provider. Um, and that's an amazing opportunity to have to help someone unlearn trauma and develop new, more fulfilling relationships, even with a professional. That really can change the trajectory of their healthcare journey. So, a trauma-informed care responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. So what we know is every interaction with someone who's experienced trauma can either re-traumatize them or not. And if we approach every interaction that way, knowing, okay, I need to be aware of the potential of re-traumatization in this moment, then we manage that much more effectively. So how do we help people heal from trauma? There are evidence-based treatments that are in the realm of mental health. Um, Again, trauma is not a mental health condition, but it is a risk factor for other mental health conditions like depression, anxiety, and post-traumatic stress disorder, which is a mental health condition. But not everyone who has trauma has PTSD, because that's a very specific diagnosis. However, psychoeducation is very helpful. The more people understand what's happening for them, the more they can develop those mindfulness skills. Family involvement and support, emotional regulation skills, anxiety management, cognitive processing, construction of a trauma narrative, and personal empowerment training. These are a lot of things that can happen through mental health care. Um, there are also complementary and integrative health approaches. Herbs and dietary supplements, seeing a naturopath can help. Meditation and deep breathing are helpful. Movement practice, this again is a very physiological process. When we are activated, our whole body is responding. And so these movement practices, yoga, Tai Chi, and Qigong, chiropractic, acupuncture, and homeopathy, these are all very helpful approaches, depending on how open someone is to the approach. I think if they believe it's going to work, it has a much better chance of working. But there are many, many ways to approach healing from trauma. And we store these experiences in our bodies, kind of depending on what happened or what our experience was. Um, it's not purely psychological, it's a physical process. So here's another way to kind of frame that. There's emotional regulation skills that are taught by all of these things on the left. Cognitive behavioral, this again is more of the mental health realm. And then you have the emotional and physical release. So EMDR is a treatment specifically designed for post-traumatic stress disorder. But a lot of these others, art therapy, drumming, psychodrama, these are things people can do at the senior center. These are things people can do at Trauma Healing Project. That's another great resource. In fact, that's where this slide comes from. So looking at the phases of healing from trauma, there's processing, stabilization, and integration. I'm not going to get into a lot of details about that, but what's common about all three are movement and supportive listening. So movement is not necessarily in your wheelhouse, but supportive listening, I'm thinking you're very experienced with that. And so what I want you to know is you're probably already making a huge difference for people. Um, I'm hoping you're learning some things today, but what I know is that you have a lot of skills that you've been applying in your work already. And so now I think you can look at those moments when you're providing supportive listening. And the difference between supportive listening and like active listening or other ways of listening is that you really are just taking in the information, letting them know that you hear them, but you're not necessarily giving advice. You're not saying what you should do is this, or have you tried X, Y, or Z. Supportive listening is really about letting them just have that moment or moments of sharing without a lot of feedback or even emotional responses. Because the fear people have who have history of trauma is if they share that experience with someone, they're sharing their trauma, and that other person is being traumatized. It's hard for people to imagine that they could tell their story without hurting someone else. And that's why they keep it so close to their heart and don't share it, especially veterans. You know, this is especially true for veterans. They don't want to come back home and drag that experience with them into the lives of the people that they love. And so an opportunity to talk about experiences, not even the traumatizing experience, but just to talk, knowing that you're not going to cause any kind of damage to the other person, um, really is freeing, and it allows people to be less cautious in how they share. Um, and it really is a way for people to let go of some things. So these two aspects of healing are really something to focus on. And they don't require a lot of effort. They just require that you maintain a level of mindfulness yourself as you're listening, that you're not tearing up, that you're not cringing, you're not acting as if this is some horrific thing that they're sharing. You're able to handle it. You know, you have strength and confidence. That's important. So, what's your role in promoting healing from trauma? So, folks who work in social services and healthcare can be a source of trauma and have been for many people, especially the people that fit into those categories of marginalized populations, people who have experienced generational trauma and intergenerational poverty. You know, that is a big source of trauma. So, people who have had to ask for help multiple generations, you know, getting food stamps, getting assistance for housing, it becomes a legacy, and people become traumatized by that in some ways. So, because the interactions with social services and healthcare can seem so kind of cold or jaded, you know, a lot of people have shared their experience with me that they don't feel cared for by the people they interact with in healthcare. Again, as a hospice organization, I know that you're putting compassion first, and I love your mission. Um, so I'm not too concerned about your interactions. What I want you to know is that people are coming to you having these experiences, and they're going to put you in that bucket before you get a chance to show them that you're there to support them, you know? So that's where the trauma shows up, is those initial interactions where people have trouble trusting you and they don't want to develop a close relationship. So people in social services and healthcare can provide a corrective experience. If these interactions are positive and constructive, it changes how people see healthcare in general. It's important to view client-patient behavior through a trauma-informed lens. So that means not taking things personally, knowing that this is the source of this negative interaction is in trauma, in someone's past experience, and that you can help them uh, get through that. So in-home care, other services supporting IADLs can be a trigger based on invasion of boundaries in the past. So just coming into someone's home, excuse me, can trigger them because they're not used to having people they don't know in their home. Excuse me. They've had experiences in the past with child welfare or any other kind of situation where someone was checking up on them or making sure they're keeping their place up. If they are on a Section 8 voucher, they get annual um, annual inspections, you know, to see if they're taking care of their place. So that can put them on edge, knowing somebody's coming to their house. Having consistent relationships and predictable routines can act as a corrective experience. So if there's any way to keep kind of the same people working with someone instead of introducing someone new every time, if there's a way to establish routines where I'm going to be here at the same time on the same day, you know, going forward, you can expect when I'm going to be here. I'm not going to show up unannounced. Um, and be aware that cognitive disorders can make healing more difficult. because new memories are less vivid than long-term memories. So it's going to be more challenging to work with someone who has dementia and post-traumatic stress disorder, or if they're impacted by trauma. So having a lot more patience with folks who have a cognitive disorder because they have a disability that keeps them from unlearning that experience. Um, so that can really throw a wrench into your interactions. So finding ways around that, working with family members, trying to develop that relationship, but knowing that there might be some obstacles just because of a cognitive disorder. So this is a graphic that kind of describes everything I've been saying, kind of all on one page. So trauma-informed care recognizes that traumatic experiences terrify, overwhelm, and violate the individual. So these are experiences they've had in the past. Um, and trauma-informed care is a commitment not to repeat those experiences, in whatever way possible, restore a sense of safety, power, and worth. So on the left, you see kind of the actions of the organization. So a commitment to trauma awareness. You're demonstrating that right now by having me on for an hour to talk about trauma. Understanding the impact of historical trauma. We've talked about that as well, how people can bring experiences even from multiple generations past with them to their interaction with you. And then developing policies, procedures, and practices that do all of these things. Now, what I think is important to recognize here is that we're not just talking about the people that we serve. We're also talking about you, about employees, about healthcare providers. We're not immune from having a history of trauma, right? And in fact, a lot of folks enter the field of healthcare or social services because they have had trauma in their past and they want to help other people any way they can. And the way that they're helping people helps them feel better about their own trauma history. So don't assume that everyone around you is free from this impact. So we need to do this not only for the people that we serve, but for our own staff, creating a safe context. So thinking about all the places people have to go. Do they have physical safety? Is there trustworthiness within the organization, clear and consistent boundaries, transparency, predictability, and choice? These are things that need to be offered to your staff as well as the people that you serve. Restoring power, again, comes down to giving people choices and empowerment, coming from a strengths perspective and building skills. When people have choices, they feel in control, and they're less likely to be activated in a situation where they feel like they have control. It's when they lose control that people are more likely to be activated. When they're not given choices and they're just told what to do. We've all felt that through the pandemic, and no one appreciates it. Um, Promoting self-worth, collaboration, respect, compassion, mutuality, engagement and relationships, acceptance and non-judgment. So again, these are ways to counter the trauma that folks are bringing with them when they're getting services, but it's also a way to look at your own organization and see, am I doing this for my staff? Do we have um, mutual respect? Do we collaborate? Is there a sense that people's needs are met on an emotional, social level in this organization? So that is also part of being a trauma-informed organization. And then I have some slides on mindfulness. So why is mindfulness even part of this topic? Because trauma, again, is a physiological process, and it's one that we can feel very out of control when we're activated or triggered. So it's important to practice being in control when we're not activated or triggered. It's just like a competitive sport. You're going to practice in a low stress, comfortable space, free from distractions. If you want to be really good at making baskets, if you want to be really good at basket weaving. It doesn't matter what it is, you're going to practice in a low stress environment without distractions and really focus on what you're doing. And then if you're forced to do that out in the world, basket weaving competitions, you can do it in a stressful environment and you have the skills, right, from that practice. So that's why mindfulness works for people who have a history of trauma, because when they're not activated, they do have full engagement of their prefrontal cortex, and they do have the internal resources to develop these skills. But when they are activated, all of that goes away. But through mindfulness, they can learn to hang on to it a little bit, or recognize when they're starting to lose their grip on their mindfulness, and start to take some deep breaths, maybe walk away from that circumstance. They figure out what are the environmental triggers, what are the interpersonal interactions that tend to activate me, who are the people that tend to activate me, and do I really need them in my life? Do I need to have better boundaries with those people? There's a lot of different ways to modify and adapt, but a lot of it starts with really thinking about these issues when the prefrontal cortex is engaged in a safe space away from distractions. And that's what mindfulness allows for. So it allows for people to become calm, which is where we make our best decisions. When we think about our long-term goals, think about our relationships, gives us clarity to make, again, good decisions, and maintain a sense of humor, balance, and ability to function. Optimism is vital to resilience because it allows you to avoid rigid thinking and maintain some flexibility and adaptability. When we're optimistic, we can change our minds about, oh, well, this isn't going to work, I'm going to do something else. When we're feeling pessimistic, the first obstacle that comes along is failure, and we're done. We give up. And then happiness, hopefully, is the result of all of those things. And this is from a book called 101 Mindful Ways to Build Resilience by Donald Altman. So the rest of this slideshow is ways to practice mindfulness. And I'm not going to share those right now. I'll be sending the slideshow to Becky, but feel free to look at those. And at the last part, I have resources. So what I want you to look at here is near the bottom on the left-hand side, we have the Trauma Healing Project. They have classes, they have yoga classes, they have acupuncture, they have art classes. Their website has a full schedule, and most of it's available on a sliding scale, so it's not very expensive. So check that out. You can make referrals to the Trauma Healing Project for people who have a history of trauma. And then you have the Eugene Vet Center. So this is where veterans can go for free counseling. They don't have to go to the VA. They don't have to use any kind of insurance. Just being service connected, I believe, is enough to get free counseling. And if you look at their website, there's a lot of other services that they offer as well. There's weekly groups, there's family counseling, and they make referrals also to other services. Trauma Informed Oregon over here on the right is where I've basically learned the most about trauma. They trained us to provide training to our staff, but that's a great organization to contact if you want to really dive into trauma-informed care as an organization. Here's Donald Altman and his books, and then the 2 articles that I referenced during the talk. And that's what I've got for you. And I want to know if you have questions. Got 4 minutes. You got a question?
I was just going to say, I have kind of a question and a statement.
Okay.
I think one of the most difficult things that for me has been, yes, I know the things that someone needs to do, but getting them to be open to the idea of reaching out to other people or practicing mindfulness. Sometimes that can be difficult. You've given us some simple ways to do that. But I think you also make the point that practicing those things before you're in that challenged state of mind or facing trauma is important.
Exactly.
And so I just want to like offer to the group that's if you do have people that you're working with who are open to mindfulness practices, whether it's movement or visualization, I'm certified to do those things, and I would love to be able to lead them for our patients on a more consistent basis. So just wanted to throw
Great.
that out there because I don't think everyone knows that. And
Yeah, I'm glad. And I've been to at least one of your talks and very impressed. Totally different approach than mine, which is great. Much more experiential and yeah. So I appreciate that balance and having access to that. That's amazing. Any questions from the group?
Not really. You, as always, do an excellent job.
Thanks, Morgan.
It's really appreciated.
So
This is something that we all deal with, and I'm glad that there are nurses on, because
yeah,
my nurses end up doing a lot of social work.
yes,
So it's really, really good that they're here.
great, absolutely. Yeah, my hopefully soon to be daughter-in-law is a nurse at Riverbend. She works in post-op, and so she hangs out with people after serious procedures and kind of helps them get back to their lives, or the rehab or wherever they're going. And I feel good knowing she's there because I know that she's providing emotional support to people. And the difference at the hospital, if you don't know, is that you don't really get visitors. Used to be that you could have someone kind of hang out with you most of the time at the hospital, and now it's just locked down. They don't allow people in. So the loneliness in those kind of facilities, being stuck in the hospital for days at a time, it's just rough. So yes, nurses, thank you so much. And I'm hoping that nurse training programs are integrating some of this information at this point and providing it to new nurses, but I'm not sure. So the vet center, I want to say something else about that. If as an organization you want to dive more into veterans as a topic, on their website it says that they have the capacity to do presentations. I wasn't able to get someone to come to this, but that is an option if that's something you want to explore. And they're a great organization. I know a couple of people over there, so really great to work with. And they're in Eugene.
I also got some really I just got back from a couple of days of training at Bristol Corporate.
Okay.
And they gave me a couple of really great books. And we have been, as an organization, doing some books. So I think I'm going to order those. One is by an author, Deborah Grassman, who was a hospice provider for a huge veterans organization. And it's called The Hero Within. And then the other one is talking, like you were talking about, mindfulness and the need for activity. And it really explores how we can deal with trauma. So I'll get those out to the staff, and we'll probably order some to the office for those that are interested too. So
Fantastic.
Thank you, everybody.
Thanks. Really appreciate it. And let me know if you want other training on other topics.
Thank you so much, and
I'll
thank you
take
for letting
any
us
training
record.
you offer, Chris.
Awesome.
Take care.
yeah,
Have a great day.
you too.
You as well.